both jaws are too far back, but the lower is further too far back than the upper. In those cases, the upper is generally already too far back. So to do something that's going to pull it back even more is going further in the wrong direction, and it's not following the best principle, which is do no harm.
Hello. That's how it's done. Keep it. Hello, everybody. Zach Couples here, bringing you an episode of the Zach Couples Show. My hope is one of many live interviews, and I couldn't think of a better person to start with than my guy, Dr. Brian Hockel. You may have never heard of him, but he is one of the pioneers in the dental field when it comes to improving upper airway dynamics. If you are someone who struggles with sleep apnea, or you've been diagnosed with upper airway resistance syndrome, you're feeling groggy, you grind your teeth, this is the podcast to listen to. You may not have ever considered utilizing a dentist to improve your breathing through your nose or to improve your sleep, but it is one of my top referrals that I am looking to get into with my supreme clientele. We talk about all types of things in this interview. We go into how different appliances or different treatments can improve room for the tongue, which can open up the upper airway and allow you to breathe better while you're sleeping, among other things. We go into why sometimes traditional orthodontics are bad. I mean, especially if you're someone who has had failed orthodontia in the past, this is a great episode to dive into that. The importance of the tongue position in terms of improving upper airway dynamics, all types of awesome stuff. And we are very lucky because Dr. Hockel is one of the pioneers in the dental field. I mean, as I was editing this, I was taking notes for the podcast because it's that good. I'm going to give you a quick bio about my guy, and then we'll dive into it. So for Dr. Hockel, he's a graduate of University of California, San Francisco School of Dentistry in '89. He's a general dentist in private practice with a focus on orthodontics that aims to prevent or treat airway problems like sleep apnea. He aims for a more permanent solution to airway-friendly smiles, going beyond the dental oral appliance approach, often having to reverse previous orthodontic treatments. Serious. He has lectured nationally and internationally on topics of facial growth guidance, orthotropics, and airway orthodontics, and is an orthodontic instructor for the Academy of Airway and Nathologic Orthopedics. He is also co-founder of the Team Airway Study Club, a co-founder and board member of the North American Association of Facial Orthotropics, and a board member of the AAGO, a.k.a. this guy is serious in the field. There's going to be a bunch of show notes if you want links to find out where you can find Dr. Hockel. Check it all out on zachcouples.com/Hockel. That's Hockel. zachcouples.com/Hockel. I will give you all of the notes that you need to be successful. There's going to be transcripts, the video, if you're watching this on audio. Check it out. So I will leave you alone, and let's give this interview a shot. Well, Dr. Hockel, thank you so much for flying to Las Vegas just to come on this podcast.
It's an honor, Zach, and it's going to be entertaining for me too.
Yeah. Well, I'm beyond excited to have you here to talk about this stuff because people who I think highly of speak incredibly highly of you, and I guess I want you to kind of let the listeners and myself know. It's like, why am I flying to see you to help me with my mouth? Why am I not just going to Joe or Jane Blow down the street as a dentist? So what makes you different and what your approach is compared to other people?
I think a lot of it has to do with just the understanding of how we get to where we are and what the underlying causes are of some of the problems that we're dealing with, and then the connections to what we're doing in the orthodontic world, the orthopedic world. So by that I mean, if you understand that our growth really affects how our function, especially of the airway, but certainly of the jaw joints and of the bite, how those relate to each other, then you can kind of unlock a key to how we should approach the treatment. In other words, just to give you an example, if someone says, we are the way we are because of our genes, we're just going to grow, this is a set shape to the skull, a set position for the jaws, and it is what it is, and just make the teeth fit within that confines of the skeleton, that's going to lead you to a very definite approach in orthodontics, as opposed to the belief that the way we posture our mouths and the way we use the muscles of our mouth and head and neck, that's going to affect how our face grows at a young age. And then as an adult, it's going to affect the function of the airway, again, of the joints, and that maybe if we look for the underlying causes and address them, we can have other successes beyond just getting the teeth to fit. So it's looking beyond how the teeth fit together and looking at the overall structure, jaws, airway. Turns out the roof of the mouth is the floor of the nose. So the nasal airway is our next door neighbor that way going up, and the oropharyngeal airway right behind the tongue. We're always looking at the back of the throat, but we don't recognize that that's where the air has to go to be able to breathe. So there are neighbors in the dental world, and it turns out things we do affect them.
It's a lot more than making a pretty smile in terms of the impact that you can have on someone's health and well-being. And what kind of implications or negative things have you seen from people who don't respect that? So, we've kind of spoke before having this conversation about some people who are just doing retractive orthodontics, which maybe you can talk about, or they're just, pulling teeth so things can fit, the smile can look nice. I guess, what are some of the implications of not taking into consideration the structure of the face and the things like that?
It might be an overstatement to say that most orthodontists are focused on just making the teeth pretty, because obviously there's a lot of science that goes into how we try to make the teeth fit, and we do talk about and think about the jaw joint, and nowadays, thank goodness, there's even a little bit of focus on airway, although it seems to be more of lip service than anything else. But I think the best way to answer your question would be to use a term that was coined by Dr. Bill Hang in Southern California. He calls it ERRS, extraction, retraction, regret syndrome. And he purposely called it errors, or ERS, however you want to pronounce it, because it's kind of based on the answer to your question. What are the errors that we've been forced to live with? The first is kind of an aesthetic one, where people don't like the way they look. And with a lot of traditional orthodontics, there's a feeling like maybe the teeth are further back in the face than they should be, or the lips seem sunken in or thin. There might be a feeling like the face has lengthened after orthodontic treatment has been done. Then there's the whole functional side, and this includes both the airway and the jaw joints, and it also includes the bite, of course. The way the teeth fit together can be affected by that. How we chew, how we breathe, they can go hand in hand. If you bring teeth too far back in the face, the tongue doesn't have enough room. Now the chewing motions of the jaws can be affected, and of course the dimensions of the oropharyngeal airway can be affected. So there's the functional side. And then that, of course, leads to the emotional side. So aesthetic, functional, and the emotional side. People who live with this for a long time and have been told this or that thing is all in your head, and you just need to learn to deal with that. And we as in the orthodontic profession may be saying, your bite is fine. Everything fits together. It meets every possible standard or criteria that I could have treated it to. So whatever you're not happy with, it's not what I did. And maybe I did treat to the best standard of care that's out there, but we're learning now that there are things beyond what we've been held to and by ourselves and others, and what we try to achieve, that have really profound and far-reaching effects that we weren't even aware of.
I mean, you just think of this area of the body. You have most of your sensory systems there, the brain's there, a lot of prime real estate that could potentially be influenced in one direction or the other. So it's intriguing that you're saying the wide-ranging effects that can happen on this. And I remember there was a study I read, this was several years ago, but it was people who had PTSD. And they put an appliance in the person's mouth as treatment in this randomized controlled trial, and had a profound impact on symptoms. So, like, we can have large, substantial changes on someone's health and well-being by affecting this area of the body in the way that you're talking about. Now, you weren't always into the airway side of things. So what, in your career led to you appreciating this side of dentistry more?
Oh, I think it was contact with doctors like Bill Hang and John Mew. John Mew is an orthodontist in the UK who, for many years, developed treatments that were based on what he called the Thetropic premise. And that was the belief that the jaws are going to grow to the position that they most commonly adopt. So keep your jaws closed, pointed forward, they're going to grow forward. Keep them apart, pointed away from each other, they're going to grow away from each other. It turns out that the treatments he was doing to get the face to grow to what was a better proportion, more aesthetically pleasing result, it was also making a difference with the airway. And initially, he didn't really even realize this. So he's one of these people that looked at the results of what he was doing and actually saw something really good. There are a lot of us that looked at the results of what we were doing with more traditional methods and saw that we weren't doing things that were good. So the contact with John Mew was very influential to me. Bill Hang, who I already mentioned, probably the biggest influence on how I've been able to connect the dots with airway and the relationship of airway to what we do in the orthodontic and orthopedic world. So yeah, I mean, I thought I had every answer that I needed at one point, and I suppose sometimes we get that sort of a state of pride in our careers.
Yeah.
And at first it can be unnerving to learn something new, but then you can get to a point where you're kind of in a zone, and you feel comfortable. And I felt like I had a tool to treat pretty much every type of bite problem that I could come across. And it was right then that Bill Hang dropped into my life and taught me to look at things in a very different way that included growth direction, growth guidance, developing more space for the tongue, looking at the oral posture, and especially looking at what was happening with the airway and how things affected that. And like most of the people who've heard Bill Hang, there was some of it that I readily accepted, and other things I was skeptical about. And I had to go home and think, I don't know if he's really right about what he says about the Herbst appliance, for example. I'm going to go home and just kind of look at my cases a little more critically. And I just shook my head. He was right. I mean, there were things going on that I didn't want to have going on right under my nose because I wasn't paying attention to it. So now my attitude is just don't cause any harm. Don't do anything that's going to make anything worse. And if you're doing something that has made other people worse, and you're not sure if it's going to make this person in front of you worse, just don't do it. It's the safest thing to do.
Yeah, yeah. And I imagine, too, if you're not taking into consideration things like oral posture, airway, things like that, just because of how important respiration is, you could have a wide-ranging effects of doing harm that you didn't know you were doing.
Right. Or at least miss the opportunity to do good.
Yeah.
To me, that's just as bad. You know, if I had an opportunity to do something a lot better for someone and I missed the chance, it just, I don't like that.
Was that hard for you to have that kind of paradigm shift?
Yeah, my wife would tell you I was in a very difficult mental state during those years.
Yeah.
It was a big paradigm shift and very emotional. And around that time, we had a lot of little kids around the house. So we were talking about this earlier, what it's like having the kids at home. And yeah, the stress of life combined with the stress of what am I doing in the thing that I think I do the best, maybe the foundation isn't as solid as I thought it was. Yeah. And I suppose that could happen again, and if it does, that's okay. You know, I need to keep growing and learning. So I'm not going to be foolish enough to think, okay, I've found it all. Now I know what I need to know, and I don't need to go any further.
Yeah, that's when you know you got to retire or quit. That's when I hear people say that. That's I think it's a testament to who you are as a clinician, because it is very easy to hang on to cognitive dissonance when we are approached with something that goes against what we believe is true. So kudos to you for that. So what type of people who go down this route for you, like what are these types of clients looking like besides, bald-headed jokers who want to get their sleep maybe an ounce better like me?
Well, that's an interesting question. What are the types of patients who find me or seek me out? It's definitely a certain type of patient. I mean, it's not the kids up and down the street that need braces and just kind of assume they're going to go through the braces mill. And so, a local orthodontist builds a big, beautiful building on a really main road, and I might feel threatened by that if I were in the just kind of run-of-the-mill neighborhood orthodontics business. But I look at it and I think, well, there's a place for that. That she's doing something that's very different than what we do. And they talk about a category of one. And if you can establish yourself as a category of one, which I didn't really set out to do originally, but I feel like I have been able to do successfully, I think the people that search me out know that there are important ramifications of the types of treatment we do in orthodontics and in growth guidance, and they don't want something bad to happen to their kids, or they're an adult that has already seen something happen to themselves. And we talked about extraction, retraction, regret syndrome, and there's either an emotional component or an aesthetic component. More often I see the functional component, and people will come wanting to know what they can do to improve their situation as an adult. And some of them might come very bitter about what was done with them in orthodontics. And it's unfortunate because the person who treated them was only treating to what the standard of care was at that time, and they probably did a very good job. I don't see too many people who were treated by orthodontists who did a bad job. They were just doing it with a very different philosophy of how to treat and why to treat. So there's those, the moms with the kids that want them to grow right. So that's a group of people who have young kids and they want to catch them as early as possible. And they're bringing in a 6-month-old. And what am I going to do with a 6-month-old? You know, I'm not going to make appliances. But I like those appointments because I can talk to the parents about what to look for, how to, you know, stay away from bottles and pacifiers and sippy cups. I'd rather get them at 6 days old and talk to them at that point. You know, make sure there's no tongue tie. Make sure you're breastfeeding as long as you can. Try to switch to solid food as early as you can. The whole concept of baby-led weaning. So it's not classic orthodontics to talk to a parent about their child when they're that young. And yet, if they follow what advice I'm giving them, it can help minimize what I might have to do later on, or God willing, put me out of business. I think the goal would be for us to really find as far upstream as we can go to find the causes that can be addressed so that we don't have to treat them at the stage where we are. Even at age 4 and 5, when I'm treating a child that young, in a way, it'd be better if I could have got them earlier.
Yeah, it seems like even the concept of having your child have a tongue tie release is very controversial. Like I read stuff on the internet all the time where it's like, oh, we don't need to do that. And it's unfortunate because it can definitely negatively impact things like breastfeeding and things of that nature. So let's say I have a kid, Dr. Hockel. Maybe I find, you know, we were talking about marriage before this. I find the woman I love and we have a kid and I say, Dr. Hockel, do unto this child what we can do to minimize any negative effects. Yeah. What would be the least likelihood that they would have to do something like some of the stuff that I've had to do later on in my life? Like, where would you start?
Well, those things that I just kind of tossed off on a little bit of a list. When they handed me that little scissors to cut the umbilical cord in the delivery room for my kids, I look back on it now and think I probably should have just looked around and like lifted their tongue, gone, okay, I'll just do that first and then I'll cut if they needed it. And some of them did need it, and one of them's in college now, and I don't know, it's a different thing trying to convince your college-age son to deal with something like this, but I can tell speech differences and I know it affected the growth. Yeah. So yeah, I mean, tongue ties, when they're really, really bad and a lactation consultant picks it up and says you're not able to breastfeed because of the tongue tie, they deal with it. Or if a speech pathologist says your child can't make those sounds because he's tongue tied, they deal with it. But there's a wide range of restricted mobility of the tongue that can come before you ever have any of those kind of troubles. And it does affect the tongue posture. And there's research that's being done now. It's going to take time for it to change, but Soroush Zaghi and others are trying to do research, and they showed at Stanford that when you have a tongue tie, there's a correlation with narrow palates. It kind of makes sense. It's common sense. The tongue is the scaffold of the palate. So if it isn't able to posture up against the palate, how is it going to grow wide and up and forward? It's going to tend to be narrow and down and back. So yeah, I mean, the tongue tie, even for adults who are already grown, we're not expecting them to grow differently if they get a restricted frenum released. However, we know that the muscles of the head and neck can be in better balance with good oral posture. Having the tongue down low, cranially, I'm not an expert in cranial osteopathy, but I'm told that the cranial bone, the balance of how they fit together and move, you know, cranial bones move, right?
Yeah, I do. Joe's going to laugh that.
Yeah, so the way that happens can be affected by whether the tongue is up against the palate, where it's supposed to be. So some adults will report some wide-ranging improvements of symptoms, and you got to be careful about that because they'll tell their story on the internet, and somebody else thinks, oh, if I just go get my tongue tie released, all my troubles are going to go away. Yeah. But yeah, it is controversial, probably because there's such a wide range of techniques in doing it. Back in the day, I got my laser in 1999, and I thought, oh, there's a tongue tie. I'll just release that tongue tie with my laser. And it's like getting a lightsaber on Star Wars, and there's no bleeding, and all of a sudden the tongue can just elevate really easily. And mainly all I was treating was that flap of tissue on the outside, not knowing that there were deeper fibers that of fascia or even the mylohyoid going deeper that need to be dealt with. And then the scar tissue would come because I wasn't having them do exercises afterward. And the scar tissue ends up restricting the tongue down even more than it was before. So doing it the wrong way is oftentimes going to make things worse and not really any better at all. So the data points that people have to compare to are very limited. And there isn't a body of knowledge out there of training. It's changing slowly because people know improvement when they feel it. And you can't put an idea in somebody's head that effectively that after I do this, all of a sudden you're just going to imagine that you have a tension release in your whole head and neck area. They're going to tell you stuff like that. Or you see a child who has a tongue tie and you get a certain growth direction improvement and then don't treat the tongue tie and you see the growth direction tend to drop back. That's kind of the lost opportunity side of it.
Yeah.
You want to get everything going in your favor for optimal mouth posture.
Now, if you have someone who, say, you have a child breastfeed, any tongue tie issues are taken care of, and maybe they've even done some early myofunctional therapy to improve resting tongue posture, and maybe they've addressed any nasal airway patency issues. Have you seen them not need your services from either a orthotropic or orthodontist standpoint down the line? Or do you think, and this is maybe channeling some of Weston Price's stuff, because we've had this alteration in head position and cranial shape for so long that there's still some need of you doing some things to advance the cranial growth.
Yeah, I mean, if I had seen that happen here or there, that's such a small number of patients. It's really anecdotal, and there's confirmation bias. I mean, I'm not so sure how valuable that would be.
Yeah.
I do know that I see patients who were breastfed very early on, and their parents follow Weston Price. They feed them really well, try to avoid sugar and stuff. They avoid bottles and pacifiers, avoid milk, avoid wheat. And they seem to be doing all the right things, and yet there's still issues there.
Yeah.
So there's so much that we don't understand about it.
For sure.
I feel like we're just at the tip of an iceberg, and we're doing our best. We know certain things do affect it, and we're trying to change those, but we don't know everything. And I can sympathize with the mother who says, but I've done all this. What else do I need to do? Well, sell everything you own, give it to the poor, and then, maybe, I don't know.
Yeah, it's hard because, especially just in health and wellness, it's like people want to do everything right, or they eat healthy, they're sleeping, and they're doing all of this, but sometimes there are, genetic factors, epigenetic factors, and exposomal factors that are the rate limiting step that are out of your control. And it's unfortunate, but like life's not fair either. Right. So I get that. So say someone did all those things, but they still need your help from an orthodontic or a dental perspective. What does your intake process look like to let you know where you need to put someone? And that could be with you, or that could be triaging to someone else.
At what age? I mean, it kind of varies by age, and it depends on what the concern is.
Let's say kid first. I'm thinking someone in the orthotropic age range, and we can talk about what that is. And then maybe someone my age, right, who has some mild sleep issues, nasal breathing issues, things of that nature.
Well, I like to look, going back to the kids. So kids in orthotropic age, it's a narrow window, because orthotropics is growth guidance. And if you're trying to guide growth, you need growth to be able to guide. And there are actually a couple different windows where you can do it, but for practical reasons, it tends to be a better fit somewhere in the age 7, 8, 9, 10, maybe 8, 9, 10. In England, they'll say 8 is too late. But in America, we tend to do it 9 or 10 as well. The older you get, the less growth there is, and the less cooperation there is to be able to do what's required for the treatment. So guiding growth, and starting at that age, say 7 or 8, you want to look at how the face is growing. You want to look at imaging to see how the airway might be restricted and where. You can't make a diagnosis from the imaging, but it's a glimpse into what's going on in the nasal airway, the oropharyngeal airway, and tongue posture sometimes. And then you look at obviously orthodontic issues like how the teeth are fitting together, how the jaws are fitting. If the jaws have not grown as far forward as they should, and there's an oral posture issue, those are two things you can consider affecting at that age. Younger than that age, it's harder to make a change with how the jaws are growing with appliances and postural changes. And after age 11 or 12, it's very, very difficult. So during that time, you might consider that as a treatment. I had two boys in yesterday morning who their faces were tending to grow more downward and backward than they should. And I always say, welcome to our world. I mean, that's all of us to one degree or another, much more so than our ancestors a few hundred years ago. And I looked at their imaging, I looked at their teeth, I looked at the questionnaires and my notes from their exam, and I thought, I think they could really benefit from just simply widening out the dental arches, giving the tongue more room, giving the teeth more room, and then releasing the tongue ties that they both had and retraining them on their mouth posture. Then I got their sleep studies, and I had a feeling there was something going on with the sleep when I had seen them early on. They both had polysomnogram, overnight sleep studies, and they both had apnea hypopnea indexes, not upper airway resistance, but they actually had sleep apnea at over 11 events an hour. For a child, that's severe. So it would be like, for you and me, it'd be 32, 35, or 40 times an hour.
Yeah.
And when that happened, the scale, you're trying to balance the pros and cons, the scale just went clunk toward the orthotropic side, meaning it'd be worth the cost, the time, and the hassle if the parents and the patients were candidates for it. So cooperation, both by the child and by the family, is so much a part of orthotropics. It's not like any other treatments that we do. And if there's just not the family support or the discipline, the budget ability too, because there's the cost to figure in, there are a lot of factors that you have to try to put together. And what I like to do is look at what are the problems, what are this family's capabilities and desires, and then what's possible from a technical point of view. How can I put all that together in a way that's going to be a win-win and get a good result? Because had it been a family that came in where the kids were climbing up and down the chairs in the room, they weren't listening to me at all when I talked to them, and the mom's on her phone trying to carry on a conversation at the same time, talking to the dad who doesn't live with them, trying to tell him, don't worry, I'll bring him over. You know, just a lot of other challenges in life for a situation like that. Even though I knew it would make a big difference for them, I wouldn't even mention the word orthotropics, because it's going to be a frustrating and in the end not a fruitful endeavor to try to accomplish it. So that's kind of a thing of itself. Other things like what we'll do for adults might depend more on again, symptoms, concerns of either pain patterns or airway problems. That's another type of patient that will find me and search me out, is that they have sleep apnea, they want to get rid of the CPAP, they want to do something more definitive, and they've heard that there were other solutions and they just want to see what those are. Or maybe they got referred by someone who said, you should go see this guy, and they're just on blind faith. They go, I don't know, so-and-so said I should come see you. That's a little difficult conversation to start with, but I get those people too.
Yeah, well, especially if they have things that are undiagnosed that now you got to bring that to the forefront. It's like, oh, this is kind of serious. We might need to do something about that. So let's talk more about adults. Most of the fam who are tuning in are definitely adults, and they're really diving into this stuff, and they're trying to figure out, like, it's funny, I have like 3 friends who I haven't talked to in a while, but on Instagram, and everyone seems to be getting stuff done to their mouths now to try to get this taken care of. So an adult comes to you with some of the issues that you've mentioned. You're doing a sleep study. What is kind of the options for someone? And I know this is probably going to be very expansive because it could include PT, it could include myofunctional therapy, but if we just restrict it to, I'm going to improve the structural things of this person's upper airway, what does that look like?
So if the airway is the problem, so your givens for me are that there's an airway problem and someone has sleep disorder breathing of one kind or another, and let's take it as a given that they don't want to be on a CPAP the rest of their life. I can't imagine why, but let's say they don't want that. And so your question is, what's the discussion about options?
Yeah.
generally. I mean, everybody's different, but I can say there are a lot of commonalities, enough so that you've seen the poster that I use to describe this. And I'll say if you have an obstructed airway, the three general ways of approaching it are push harder on the air going into the airway. That's the CPAP option. And usually there's kind of an X through that option. But for a lot of people, it is a realistic option. Let's say these boys who were in yesterday, severe sleep apnea, I told them you need to follow the doctor's recommendation, and the medical doctor, the ear, nose, and throat doctor happened to be in the office at that time, and we were talking about how CPAP could actually be a viable first aid option, is kind of how you think of it, is whatever we do for growth guidance and changes in the skeletal structure is not going to have an effect overnight. So just get some good sleep and get healthy in the meantime.
Yeah.
So CPAP, that's option one, push harder on the air going in. Option two would be open the airway temporarily at nighttime. And that's effectively what the dental appliances do. And when you see dentists or orthodontists talking about how they treat sleep apnea, generally it's because they make appliances like this. And there are over 200 different FDA-approved designs for the appliances, so there are lots of ways to try something and not be happy, and then try something else and not be happy. Or you get a good fit. If somebody really knows what they're doing and making these appliances, and they look at other things beyond just the appliance itself, then they can be effective too. They have their place. Everything has advantages and disadvantages, and the big advantage of an oral appliance is you don't have to be married to this machine on the bedside table. You're not dependent on electricity. You can bring it with you when you travel a lot easier. It's less bulk in the mouth. It's not as unromantic as having this thing strapped around your head. But it's got downsides too, and that is that it's not really fixing the underlying problem. It's not addressing the structural underlying problem for most people. And now maybe that's okay. Maybe they aren't able to, or they don't want to deal with those underlying issues. They just want to be healthy now. So, but that's a downside to it. The other downside is that it's anchoring a lot of force, pulling the lower jaw forward on the upper teeth. So there tends to be a reciprocal effect on the upper jaw of pulling it backward. And over time, that can allow for changes in the bite, how the teeth fit together, or even in the jaws themselves. So it may not be the end-all be-all for many, many, many years for everyone, although there are people who've gone many years and have not had bite changes, but you just don't know if you're going to be that one. So it can help. It helps with the cardiovascular effects with sleep apnea, which CPAP does not.
Yeah,
so
why is that?
They don't know. They don't know.
So interesting to me.
It is.
Because they say CPAP will save lives, right? But if you're not getting the cardioprotective effects.
When my dad heard that, he said, what, should I just give up on my CPAP? I said, no, Dad, breathing is important. You need to be able to breathe, and without that, you might stop breathing in your sleep. You will stop breathing, and that's not a good thing. But it's kind of an artificial breathing, forcing the air in and out, and the parts of the brain that control your breathing are like, all right, don't need us anymore, and may become less responsive over time. And I don't understand the physiology of it completely. I mean, I know it's better than not breathing, and it does save lives when it's worked, but the compliance goes way down after 6 months or so, and for a lot of different reasons. Feeling claustrophobic, drying out the airway if it's not humidifying it, restriction of movement in bed, just the hassle of wearing it, the feel of it on the face. A lot of reasons why people might not want to wear it, and for them the dental appliance might be a good alternative, and it's got the added bonus that it turns out it does help with the cardiovascular effects.
Is it effective in severe sleep apnea?
It can be.
It can be?
It can be, yeah. The medical doctors will often tell you if you're over 30, you just have over 30 in your AHI, the score of how severe the sleep apnea is, you should be on a CPAP. But if you're under 30, you can try an appliance. There is no clear-cut division like that. And my friend Pat McBride has treated more people than I know using appliances like this, including a lot of people with very severe sleep apnea, and she's been very successful at it. So I think a lot of it has to do with the skill of the person making the appliance and how they adjust it, what else they do in addition to it. Do they work on vitamin D levels? Do they work on nutrition? Do they look at overall markers in the body? Do they look at the breathing mode? Are they taping their lips together? Or is the nasal airway clear? There's a lot else that can go into it. The tongue tie for some people can make a difference. So it can be a part of a good regimen for some people, but then there's that risk of the bite changing. Option 3 is more structurally open the airway. Do something so that the airway is able to be more open by changing the structure around the airway. And the main ways that we do that, ear, nose, and throat doctors do the same thing with different types of nasoseptal surgery or reduction of turbinates or any number of things there. But what we do in our world is either move teeth to a different position to allow more room for the tongue to come forward out of the way of the airway, or work with an oral surgeon who's able to move the jaws themselves into a more optimal position. So in both of those cases, you're trying to change the underlying structure. And they have the potential of being a more definitive change to the airway, but they're also more involved. Going through orthodontics takes time, and going through double jaw surgery, first of all, it has to be done right, and a lot of the times it isn't as effective as it should be. But even when it's done right, it's still an expensive, invasive, involved procedure. So everything has pros and cons. But in our world, I think dealing with the orthodontic side of things and orthopedic, what can we do to change the shape of the jaws, either by moving teeth or by moving the bones of the jaws? Well, that's more for kids, even though we're talking about adults now. Or looking at the orthognathic surgical option for some people as well.
Gotcha. Yeah, no, that's perfect. And I appreciate you listing out those options, because I want people to know, like, if you do have some type of sleep issue, like I had a guy reach out to me where he's like, I got my CPAP and my numbers are good according to my doc. Do I need to do anything else? And it's like, well, it depends, right? If we're just looking at pure symptom management, you're probably okay. But if you want to fix the underlying structural issues, maybe we do need to go down a different pathway. Since I have you here and this is your bread and butter, I want to talk about the third option, which is using appliances or devices to expand the airway, because especially in my field, we have a lot of different options, or people are trying different appliances for different things. And I think there's some confusion in terms of how these things work and what they're used for and which ones are useful versus not. So there's some confusion in terms of, because you've mentioned that we'll use appliances to move teeth. And for the people tuning in, if you hear me being lispy, that's what I have been. So there's some people who would argue, or who maybe say that they're actually moving or they're creating bone growth with some appliances versus you're saying moving teeth. So what is the underlying physiological way that an appliance that I have works, and what is likely not happening?
It's a good question, and it's a hard one that I don't have a full comprehensive answer to, but I'll tell you kind of what my thinking is on it today. Bill Hang calls it the alphabet soup appliances. We've got the AGGA, DNA, ALF, all these different types of appliances that are out there.
And they're all 3 or 4 letters.
Right, yeah.
Same thing
yeah,
here.
pretty much. So, but like you say, claims are being made about growth of the jaws, and I'm skeptical of that in the way they make it sound. When you move teeth, you don't just move teeth. You move the teeth and you move the bone around the teeth. And technically, that alveolar bone is part of the upper jaw and the lower jaw. So yes, you're expanding the jaw by moving the teeth, but you're not really expanding the jaw when you think about the basal bone, the roof of the mouth, the hard palate. In a child, you can do that. In a child, you can much more dramatically change the shapes of the jaws. You can apply pulling forward force with something that touches the chin and the forehead, and rubber bands come forward out of the mouth and attach to that reverse pull headgear. Not like the old headgear that pulled things backward, but a reverse pull headgear at the right age can bring the whole upper jaw forward. That's moving the base of the jaw. The appliances that are out there now that are talked about as changing the bony structure, stimulating the there are a lot of different explanations that are out there as to how it happens, and there's some very detailed scientific explanations behind it. But I think the bottom line is, most of the time for adults, it's not a huge order of magnitude in terms of the growth changes. Now, you're going the right direction if you keep your tongue on your palate and you push it up there and help your oral posture. Maybe you're going to slow the worsening of it. You're going the right direction if you expand both side to side and somewhat forward with any appliance. I mean, to a certain degree, if someone can get it done with an appliance that's different from the one I use, then great. You know, I think as practitioners, we get better with specific appliances by using them a lot, and we learn the idiosyncrasies of them. And it probably makes sense for practitioners to stick with tools that they are proficient with. But on the other hand, I think there are some tools out there that don't accomplish the same thing, even though a lot of times the people who use those appliances are talking about them accomplishing the same thing. So, for example, I'm asked a lot of the time, what about the ALF appliance? What about the ALF appliance? Derek Nordstrom developed this appliance from the Crozat, which was a light wire appliance, not as light a wire as the ALF is.
Yeah.
And his whole thinking on it was develop something that is very cranial compatible, because he was looking at what was happening with the movement of the head bones. And he found that with certain adjustments of the wires in the mouth, he could help the mouth posture and encourage the mouth posture to help develop the jaws themselves. It's a way of letting the body's healing potential come out on its own, you know, to help the body do the healing from within. As a pure mechanical tooth moving device, it's probably not as efficient, and I know it's not as efficient as other appliances would be, but it's not really fair to compare the two, because the objectives that a good ALF practitioner is going to have, where they're looking at the cranial stability and cranial health, and hopefully working with an osteopath to help that, they're doing very different things than somebody like I am is doing when I'm trying to accomplish larger scale changes in either lateral arch development or forward arch development, advancing front teeth. It's really two different things. And yet, this side will talk about, well, we're going to try and help your airway. And this side will talk about, we're going to try and help your airway. And I'm not going to be so foolish to say they're never helping airways. Of course, I mean, they're doing good things, and there are people to attest to that all over. But it's a very different set of objectives that someone might be using. Something like the anterior growth guidance appliance. The claim is that it's stimulating the growth center, the premaxilla, that with that pressure behind the upper front of the jaw there, that now the maxilla is going to grow further forward. I have yet to see either cases or research or x-rays where I've seen that kind of a growth that could be anything more than denoalveolar changes. Denoalveolar meaning the teeth and the bone around them moving. And I think they're going in the right direction. I love to see the changes of advancing the front teeth with those kind of appliances. But my question is, what do you do after that? What about the side-to-side expansion? What about the lower jaw position? What about the lower, there's more to it than just bringing the upper front teeth forward. But I think that's a good direction to go in. Do I think it's something that's happening with the epigenetic change now and activating the bone growth genes to grow? I don't know enough to say that it's not. Yeah. I'll just say that I haven't seen the cases that have shown me the kind of bone growth that's making that kind of a claim. It's a very different order of magnitude of change compared to what you would do with orthodontic surgery, where you're really, you may be going forward 18 millimeters and able to change the whole plane of the occlusion at the same time. The ALF crowd would say, but that's completely destroying the cranial mechanism. Now the bones are just kind of frozen. They're not able to move as well as they should. And I'm not going to say that they're wrong about that. I don't know enough to say when they are and when they aren't. The osteopaths I know will say, yeah, they kind of shut down for a period of time, but they work their way back to normal, that there's this inherent healing potential the body has, and that it's worth it to be able to get the kinds of changes in the structural airway that you would get. So I think that all the different kinds of appliances out there, picking the appliance you want to have used for you is like telling your contractor he should use a Craftsman hammer. I mean, maybe, why? Yeah. What do you know about the appliances? The consumer really is even a worse position than we are as professionals, and we're going to lectures, hearing other experts talk about these things, and it's confusing for us to try to piece together what's what's really going on. So for the consumer to be able to do that same thing and say, well, based on what this person said, I want their results, so I want you to use this particular Craftsman hammer. So, but on the other hand, the consumer could say, well, to me, the osteopathic angle is the highest priority, and I want to work with an osteopath. And so in the hands of that practitioner, the ALF appliance might be the best thing to achieve those goals.
It's just funny because we have the same issue in physical therapy and training. It's like you have these people who are, in these different camps and systems, and ours are also 3 or 4 letters, and sometimes we get something long like a crow's-at in terms of the thing, but the tools themselves are irrelevant. It just depends on what you're objectively trying to achieve. And it's just funny that that's the same thing here. And I actually really like how you broke it up into different camps, because this was one thing that I wanted to talk to you about a little bit, because you have ALF, which is more cranial osteopathy driven. You have the crow's-at, which I have in right now, which is more airway focused, I would say.
Well, no, the crow's-at started out as something that osteopaths like to do. And
Really?
my dad's book, Orthopedic Ethology, 1981 or 80, he published by Quintessence, and it's kind of the best textbook that's out there on crow's-ats. And the idea was that it was developing the potential that was there in the growth, both for the kids and for the adults. And they knew there was an effect on the airway, not to the degree we know it now, but there's a whole chapter in that book on cranial osteopathy. And the pictures that are in that book are used in almost every cranial osteopathic lecture that I've gone to, because they're really well done. So the thinking by the osteopaths with crow's-ats was that they were also very cranial compatible. So I'm not the expert in osteopathy, so I'm not one to say what, how to compare crow's-ats versus the ALFs, but I know Derek Nordstrom's position is the very light biomimetic forces seem to be more cranial compatible. So, but the crow's-ats, to me, having a larger body wire on them, are more effective at getting transverse arch development, especially in the back, in a more defined time period. An ALF practitioner will often go much longer periods of time than we would be comfortable in the orthodontic world wanting to have someone commit to. The objectives of the end of the treatment aren't really what's focused on. It's more the journey along the way. Let's do the tweaking we need to do now, see if that's getting you going in the right direction. And then 9 years later, maybe we're still doing the same tweaking and your bite is nowhere near fitting together, because we've been looking at the symptoms and the cranial situation, and it can go in a direction like that. And maybe it's helping people. I'm not going to say it's not.
Yeah.
It's just not what I do, so I can't comment on it, except to say that I want to have a more defined period of time to accomplish certain objectives. And in my world, I can do that. The crow's-at's a common tool that I'll use. The sagittal, the design by Bill Hang, has been a very effective tool as well. Different kinds of other expansion screw appliances. So yeah, they're different approaches depending on what you want to do. And it's really hard to say, I want this appliance. More important thing would be to say, what is it you want as a result of your treatment? People say, well, can you use the ALF appliance to do what you want to do with that particular appliance? And I'll say, yeah, but I could use my kid's watercolor brush to paint that whole wall over there too. It's just it's not the most efficient way to do it.
For sure.
Give me a roller and I'll just go like that, and there it's painted. And so I think certain things can be done in other people's hands if that's the way they choose to do it.
Yeah. So then, if the appliance isn't necessarily the key, right? Just like in our field, dry needling isn't necessarily going to be the fix for everybody, or whatever tool we have. What kind of things, because as much as I want to refer everyone to you, Dr. Hockel, if I have someone who lives way out in the East Coast, it's unreasonable. So if people are looking to go down this pathway, what are some things that they should be asking their dentist or looking into to let them know that they're with a practitioner who is not married to a tool but knows what to use to get a particular job done?
That's a really hard question, because what job do they want to have done?
Yeah.
What's their goal? I think if I could rephrase your question, it might be, how could I help people know whether they're seeing a practitioner who's going to do things that are not going to be going in the wrong direction for the airway and sometimes for the jaw joints, or better yet, that they're going to be focused on ways that they can help improve the airway. And there are other people around the country and around the world that do focus on this, and we all have our different approaches, but that's okay. So I think asking questions like, well, here's a good one. If you have a child and the front teeth seem to be a little bit ahead of on the upper than they are on the lower, what would be your favorite way to try to correct that kind of a bite problem? And I can tell you that almost all the time, the solution is going to be some type of mechanics that's going to end up pulling the uppers backward to a certain degree. We'll conceptualize in our mind that the appliance we're using is bringing the whole lower jaw forward, but that's a really, really hard thing to do. And so we'll use things, back in the old days, it was the headgear. Now it might be the Herbst, the twin block, the Carriere appliance. It could be the Invisalign with attachments on the side that brings the lower jaw forward. It could be class 2 elastics, rubber bands going from the top to the bottom. It could be, just go down the list. There are all kinds of things. Twin force bite correctors, Jasper jumper. They've invented all these different things because it's the most common malocclusion, the class 2 malocclusion, where it's like this. And I won't say where the lower is too far back. And I won't say where the upper is too far forward. I'll say where both jaws are too far back, but the lower is further too far back than the upper. In those cases, the upper is generally already too far back. Yeah. So to do something that's going to pull it back even more is going further in the wrong direction, and it's not following the best principle, which is do no harm. Don't take a risk that you're going to make things worse. So if you found an orthodontist that had a way of leaving those upper front teeth where they were, not pulling them back, and consciously trying to hold them where they are, and do something to compensate for it with the lower, you've got somebody who is really on the right track. For an adult, when there's a big discrepancy between the upper and the lower like that, there really aren't a lot of things that they can do. I mean, I have a patient who went to a local department head of orthodontics in the local dental school because her dentist had told her before he did porcelain veneers, she really should just get her bite fixed, which was somewhat like that. And they recommended that she take out 2 teeth on the upper and just pull the upper front teeth back to match the lower teeth. Very common way of fixing it. That's been done for many, many years for many, people around the world. It's considered the standard of care in many ways. But she felt that it started this whole process for her of, it was one thing after another. It was diabetes, her hair falling out. She got atrial fib. She, just all these things went downhill to her. She remembers having dreams while her front teeth were being pulled back of choking. She was having choking dreams in her sleep. And so she thought that this is probably affecting my airway health and my sleep and my breathing. This is all on her own, from her own research. And she told her doctor, you need to do a sleep study for me. And it turned out she had sleep apnea. Wow. And then she was recommended to have laser surgery from the back of her tongue to reduce the size of her tongue. They recommended double jaw surgery to bring the jaws forward. Of course, there was CPAP, which she wasn't able to tolerate. She attributes all of this to that solution to that kind of a bite, which was pulling the upper backward. So reversing that for her, opening up that space again, eliminated the sleep apnea, and we have that documented. And it also eliminated her symptoms. Her hair didn't grow back, but she felt overall so much better. And people report little things that they notice along the way when you reverse that kind of extraction orthodontics. So our experience of patients reporting what negative things they went through, the extraction, retraction, regret syndrome stuff. In her case, it was functional, but it kind of became emotional too. Yeah. And it was aesthetic too. She didn't like how her face looked with those teeth further back. And people generally look better when they've been retracted like that, and you bring it forward. Now their lips look more full. They aren't sunken behind a line between their nose and their chin. It's a big difference for her. So in her case, she's a good example of where that kind of an overjet problem, it's called overjet. This is overbite. Yep. When people have this, they have an overjet problem, but they call it overbite.
Just so people have that definition, and I know this is not correct. It's when the top teeth appear to be further forward than the bottom teeth, even though from a facial structure standpoint, that's not the case. Versus an underjet, commonly misnamed an underbite, would be the reverse of that, where the lower teeth appear further forward than the upper teeth, even
Right,
though
like
both are
that.
back. Yeah.
Exactly, even though both are back. That's the key.
Yep.
You see people with these really big chins, they're probably too far back.
Jay Leno.
Like Jay Leno.
Prime
His chin
example.
is actually not too far forward. If you put an outline on his face and kind of make a comparison to the ideal, you'd see that it's really mainly the upper jaw that needs to be more forward. And his lower, if anything, is slightly back.
Gosh, could you imagine if he worked with you? He would have the most prominent chin in the history of
No,
humanity.
he'd have a balanced face because we get the whole mid-face further forward. The
Yeah.
whole upper jaw needs to
Yeah.
be further forward.
Yeah.
And he probably has sleep apnea as a result because his tongue must have nowhere to go. You see in his smile, it's a very narrow upper arch.
Huh.
It's poor celebrities, they're getting diagnosed by us dentists all the time when they're on TV.
Yeah.
But so other things to ask about a practitioner is, do they think that there are times when it's worth taking teeth out and pulling front teeth backward? Are there cases they think that can be helpful for? And if they say yes, I would probably just go somewhere else, because if it's okay for an exception, it's probably okay as a general rule. And to my mind, I'll tell you the last time I took a tooth out and pulled things back. It was when somebody had 5 lower incisors, and I wasn't going to be able to get the upper.
And normally there's 4.
There are
correct?
4.
Yeah.
So taking one out and pulling them together, now we're just right back to where a normal set of teeth would be. Although there's a case to be made for leaving that tooth in there and allowing the lower arch to be that much bigger, and then just making the upper fit bigger over the top of it.
Yeah.
So that would be a question to ask. You can ask how they know if there's an airway problem. If they say, well, if your medical doctor has told you have sleep apnea, then I know you have an airway problem. And you might want to ask, is sleep apnea the only kind of breathing disorder that you address? And what are the ways that you address it? And if they say, yes, that's the main kind of disorder we treat, and we treat it using an appliance that brings your lower jaw forward. Well, in the diagnostic side, if sleep apnea is the main thing that's being treated, they might be missing something that's even more prevalent than sleep apnea, and that's upper airway resistance. It's a whole side to sleep breathing disorders that gets missed for kids, for thin-fit adults, people like you, or women especially. It isn't always apneas. Although the sleep medical doctor I was talking to yesterday was telling me if you score the sleep study the right way, you'll see the apneas there. It's just not things that would be traditionally called an apnea. So finding upper airway resistance as a potential confounding factor of these patients who have problems is important, I think, for the dental practitioner, either working with a medical doctor who knows what they're doing with this, or maybe helping the patient get the sleep study yourself. So that's another side to it. Are they finding the upper airway resistance? And then what are the ways that you try to treat it? If doing expansion, arch development, getting the tongue more room, and working with a myofunctional therapist, either in their office or somewhere else, to try to optimize the oral posture, if that's not a part of what they do to try to treat it, then they're probably not as deep into this rabbit hole as they should be, because that's at the outer rim of the rabbit hole. That's kind of the basics. Create more room for the tongue, however you're going to do it. Don't close spaces generalized. You could ask them, if my child has a lot of gaps between his teeth, how would you tend to treat that? And whether you do it with Invisalign or braces or whatever, to take spacing between teeth and close all that spacing up. You were talking about a friend who had a bunch of missing teeth. When people have missing teeth, the jaws don't develop to the size they should. And then if you just close all the spacing where there were teeth missing, the tongue's going to have much less room to fit into, and it's going to go backward toward the airway, and there's going to be a risk for sleep apnea.
Yeah.
So that's another common.
So the big things are, you want someone who moves things forward and outward and expands, doesn't pull things back, which would include pulling teeth being as an example of pulling things back. You want someone who appreciates sleep apnea and upper airway resistance syndrome, which I was reading some research on UARS, and they were showing that having that is actually worse from a health standpoint than mild sleep apnea. So if you're missing that, and I remember when you programmed my sleep study and we had that read by the people who had the watch pat, that you were surprised that the doctor who read that actually diagnosed me with that.
That's right. Yeah. Yeah.
Which was interesting because it is a big issue. And then anyone who's going to appreciate palatal tongue posture and doing whatever you can to attain that, working with a myofunctional therapist.
Yeah, it's the tongue posture and the lip posture, lips together at rest all the time, breathing through the nose, and the teeth either together or in near contact. So lips together, teeth together, tongue to the roof of the mouth. Those are the three things posturally that a good myofunctional therapist is going to work toward.
Gotcha. Now, I want to talk a little bit about getting teeth pulled. So, and the ones that I'm going to bring up, of course, are the ones that, they're old remnants from caveman days, wisdom teeth.
The wisdom teeth?
So I was recommended by a practitioner to get mine pulled out. I didn't get them pulled out when I was 18. I actually got them pulled out in my late 20s. And the reason why I got mine pulled out was because I had no obtrusive movements on my jaw. So are there instances in which you should have wisdom teeth pulled out?
Oh, yeah.
Okay.
Yeah.
So,
I mean, in the ideal world, we would not have to take wisdom teeth out. In the ideal world, our jaws would be further forward and we would all look way better than we look now. In the ideal world, our airways would be massively open and we'd be breathing through our nose and our muscles would be much stronger to support that kind of. We're not in an ideal world. And so taking wisdom teeth out now, it's not the best way to go. And our hope in developing more forward growth of the jaws is that there would be room for them. But sometimes there just isn't room for them, and sometimes they're at crazy angles one way or the other, and you really don't have much of a choice. So I don't know. I don't tend to focus too much on the wisdom tooth issue because as much as I'd like everyone to have 32 teeth in position the way they should, once the growth is done, even by age 12, 13, 14, there's not as much that can be done to make a difference, I think, in how much room they have or whether they come in. In my family, my dad tended to have us just keep them in our mouth, and he's like, no, he didn't want us to take the wisdom teeth out. And so I have all four of mine. I've got all 32 teeth in occlusion, but it's still somewhat tight on space back there. I think it's the case that when you leave them in, you tend to get more growth of the jaw. I can't prove this, and I don't know if there's research to show this, but I've had a lot of kids where they'll come in and maybe the general dentist has said, take the wisdom teeth out. I'm looking at them thinking, you know what, there might be room. You're only 18. Go another 7 years. Let's see how you grow. And I think that there's more and better jaw growth as a result of those wisdom teeth being there. We know that people like your friend with missing teeth get less jaw growth. Why wouldn't having extra teeth back there help encourage more jaw growth? I don't know if that's true or not, but my sister has hers, my brother has his. My son is being told by a dentist in New York that he should take his out now because he's got a big pocket next to one of them. And I'm like, you're a Hockel. You got to keep your wisdom teeth in there.
That's right.
So my bias is toward keeping them if possible. I don't just write them off. Okay, 14 years old, write a passage, get your wisdom teeth out. But at the same time, as an adult, if your wisdom tooth is sideways, pointing forward, now it's a liability for the bone integrity around the back of that molar in front of it. Better not to take that chance.
Gotcha.
And I know that there's discussion of meridians attached to different teeth, and I'm not an expert in that. People might tell you if you lose that tooth, that's going to affect some other part of the body. That may be true, but I'm just not sure what the best compromise would be. I'd rather not lose that second molar in front of it by having more bone loss there. I'd rather just lose the wisdom tooth.
Yeah, because I think in my case, mine were pointing straight forward, at least on the lowers.
There probably was nothing that could be done to try to straighten them.
Yeah.
And even if you went in and did heroic orthodontics to try to move them up, then where are they going to go? There's no space back there.
Yeah, no, that makes total sense. So, factoring in that, because you mentioned meridians, that makes me want to shift gears a little bit towards occlusion. So, when I was first getting exposed to this even being a thing, because in PT school, I mean, we never talked about when you need to refer to sleep apnea or how teeth influence things or anything. Like my anatomy is still lackluster up here. What is occlusion? Is it, from your perspective, an important thing that we need to consider? I know that they make appliances to alter occlusion. If we could just give a little overview of that, I think that would be amazing.
Sure. Well, that's kind of where I started. I was a senior in high school, and my dad said, I bet you could earn more making teeth than you could slicing salami at the deli where you're working. Why don't you give it a try? And I was like, sure. I don't know what it really involves, but that was my start in dentistry, was working as a dental technician doing full mouth reconstruction. We call it wax up, where you create in wax how the teeth should fit together, upper and lower, and it's a very precise scheme of how the teeth should fit. Nathology was where I came from, and people who are in dentistry would know there are kind of different camps of different types of occlusions. And nathology is the one that really raised the bar for how teeth should fit together. And there were certain principles you always tried to follow with it. And as a dental technician and as in early years in practice as a dentist, I focused a lot on the occlusion of my patients and trying to get the bite right. And that was kind of one of our mottos on the back of our business card. Nathology means trying to get the bite right. But it turns out that some of the things we do to try to get the bite to fit right can work against the bigger picture. So I'm not against looking at how the occlusion fits and trying to be as precise with it as you can, but that's a tree. And if you don't see the forest, then you're way down a side path that's going to be very distracting. So with the background I have, we'd always try to get the canines to touch each other to guide the jaw as it moves side to side. It's called canine guidance. And the thinking is that there's enough leverage this far forward in the jaw to separate the back teeth as the muscles are chewing side to side. It's got leverage against the muscles way back here. If the molars right next to the muscles that are chewing are the ones that are mainly hitting when you go side to side, it's much stronger bite forces, and it's a risk for wear or for fracturing of the teeth. So the idea was the front teeth protect the back teeth, and the back teeth protect the front teeth. When you close, the back teeth should touch, stopping the closing motion of the jaw. When you move side to side, the front teeth should touch so that you can bite through things, and so that you separate the back teeth in those other positions. So all this works great if you have jaws in a face that's in the right position, so that now the joint is in a favorable condition and the airway is in a favorable condition. If you have jaws that are somewhat too far back, take the case of my patient who had the bicuspids extracted and the front teeth pulled back. They did that partly because it looks better, but mostly because we're just taught that's how teeth should fit together. The front teeth should fit with overbite and overjet and close contact, or maybe slightly away, so that they can slide against each other to separate the back teeth during the chewing movements. But the problem is her jaws were already too far back. And by pulling front teeth backward to meet against the lowers for the sake of, we call it disclusion, the best functioning of the teeth against each other, it can be making things worse for the airway. It can also be making things worse for the jaw joint. When front teeth are brought back so that you have that contact, which in the nathological occlusal philosophy you want to have, then it can tend to cramp the style of the joint. The whole lower jaw can be being held in a position that's too far back. So I've had to kind of, over the years, that was one of the things in the early years of learning about airway, is how do I mix this with my, I won't say beliefs, but it's almost like beliefs. I mean, there's no research to show that this kind of occlusion is better than that kind of occlusion. Even class 1, I mean, ever since Edward Angle, the father of modern orthodontics, came up with his ways of putting a bite together, and one of them is the molars need to fit like this, what we call class 1. There's no research to show that that's any better functionally or any other way than any other kind of occlusion. So yeah, I had to balance how do I mix nathology with the airway? And I think that you always put the airway first. That's kind of the answer to the question, is and Michael Gelb has termed this airway centric. If you put, instead of having centric relation, which is what his dad and my dad and me would all be worried about, how do you make the teeth fit together when the jaws are in their center position? That would be the best connection of the two. So the tooth home is the same as the bone home, and they just work in coordination with each other. Well, maybe the bone home is pathologic, Maybe there's something about that bone home that isn't right, because maybe the lower jaw and maybe the upper jaw really belong further forward for the sake of the airway, or for the sake of the function of the joint. If the little disc gets displaced, then the lower jaw might need to be further forward. And if we do things with the bite, the occlusion, that work against that, the results are never going to be what they should be.
Gotcha.
So, yeah, occlusion, another philosophy of occlusion might be go to where the muscles are in their most relaxed or harmonious state and make the teeth fit there. Here again, in any philosophy of occlusion, if you're not looking at the airway function and I would say the jaw balance and the way the craniofacial growth has gone, if you're not looking at that first, then you might be going down the wrong path.
Gotcha. That's so interesting, because that was where I started my treatment. And it's funny you mentioned Michael Gallup, because that was the first appliance that I was exposed to and I wore, because I didn't have obtrusive movements. We were trying to do some things from a motion perspective to try to influence that. So I had that, and I definitely got some interesting changes within my body.
His dad, Harold Gelb, is the one who developed the appliance.
Oh, okay.
And yeah, it allows the bite to open, and it allows you a lot of times to bring the lower jaw forward a little bit, which can decompress the joints. So it can be good for a TMJ appliance, and without knowing it, it was sometimes also helping the airway.
Yeah, but it's also doing so without necessarily affecting the airway dimensions or the health of the airway, whereas it may be affecting other areas, like you said, the TMJ. And
yeah, there's some people that when you put a thickness between the teeth, the lower jaw rotates, and as the lower jaw opens, it goes backward.
Interesting.
So there's some people that you put a thickness between their teeth like that, and it can make the airway worse. It'll make them grind their teeth even more.
Huh.
So it isn't the same for everyone.
Yeah, that's so interesting, because that appliance, it was definitely like, oh, we're definitely bringing this down and forward, but akin it to something that's more in my domain, another orthotic, so to speak, is sometimes shoe wear is something that we can use to influence someone's movement versus not. And I've had people where we've put them in really supportive shoes and have a completely undesirable outcome from a movement perspective versus someone having those same shoes doing very well. Yeah. And it's just funny how you kind of have the same thing.
And we call them the same thing. You call it an orthotic, we call it an orthotic.
Yeah, because they are orthotics, essentially the same thing. There's a lot of other pathological processes that some people may be dealing with. So like people who have gum recession or like crowns, veneers. I don't know much about this. Sometimes I'm sure my clients and people are getting exposed to these things. How does that influence and play a role into the airway health?
Well, you did mention implants, but implants are something, if somebody's thinking about getting an implant, but they also think they may have bite or jaw position or airway problems, they've got to be analyzed and diagnosed really completely first from the big picture before putting in an implant. Because once an implant's in, it's not going to move, ever. It's just going to stay right where it is. So I've had patients where I've had to do a lot of expansion of the arches and just leave the implant where it was. So in the end, the implant's like way over here toward the inside, and sometimes you can work with it and just kind of warp a tooth out to where everything else is and leave it. But I've had other people where the implant has to be taken out and then put back in. Or you can even, kind of another crazy way I've done it before is have an oral surgeon just create corticotomies, cut around the bone where the implant is, and then I'll make an appliance so that after I've expanded everything else, he just cuts the bone around that section where the implant's sitting and then moves it out into the position where it belongs, and then we just let the bone heal there. It's way better to just don't do an implant until you know where it's going to need to end up. Yeah, I saw someone yesterday that's going to need one for an upper front tooth, and their front teeth may need to be in a different position. I'd rather catch them now and say just don't do anything until it's in the right place. But recession is the gums moving down the root of the tooth, exposing some of the root, and it's generally a function of some bone loss around the tooth as well. And it's not a good thing, but it's not, you don't look at any gravestone and see recession as a cause of death. It's usually not even a cause of death of an individual tooth, even when there's a lot of recession. It's the bone between the teeth that tends to hold the teeth in really well. So it's not, a crazy bad thing if somebody does have some recession. But having said that, you'd rather not have recession. So we look now at ways of expanding the upper jaw, for example, so that the base of the upper jaw will expand skeletally so that the teeth don't have to be moved in a way that might risk recession. Of course, there are procedures that periodontists can do to help minimize it or add bone back to those areas, different kinds of bone grafting procedures. But it's sometimes a necessary evil. But you know what? It's often a sign that something's going wrong functionally with the tongue and the tongue space. You'll see people whose teeth don't even meet together in the front, and they have recession. It's not from heavy bite forces or clenching or grinding on the teeth that caused it, which is one cause of recession. It's like if you take a fence post and shake it, the dirt kind of moves away and you're going to lose the support down where it's coming out of the ground. Well, if the bite is putting forces on the teeth up where it comes out of the ground at the gum line, the bone may be getting lost and the gums may be receding. So that would be like shaking the fence post. But in the analogy, another thing that happens is you get a cow that comes up to the fence post and just leans against it all day long. And that can also make it come loose and lose the support down below. That's the tongue on the inside without enough room, putting constant force against teeth, either forward toward the front teeth, sideways toward the back teeth. And sometimes recession is the tongue's fault and the tongue just not having enough room. So we've been talking about the airway, and when you don't have enough room for the tongue, you often want to make more room for the tongue so that the airway can be healthy. But making more room for the tongue might be important to try to prevent further recession when there's already been recession.
Have you ever seen a case where you improve tongue positioning and you give the tongue enough shape where you've had a positive change in gum recession? Because I would think with Wolff's Law, you might be able to get some bony adaptation.
No, I can't. What I have seen is sometimes if there's a little recession in the front and you bring front teeth forward, it just from the way that it's kind of moving through the tissue, the recession seems to look a little bit better. But then other times the recession just follows it along. And I don't know if there's really a pattern to when you're going to keep it or see it get worse. For some people, it will get a little worse. It's a risk of any orthodontics. You could have some recession.
Yeah.
But like I said, grafting is a possibility and trying to do things that avoid that, moving slowly, lighter forces, and get the tongue in balance too. Get the tongue enough room so it's not going to be putting pressure on the teeth as well.
Yeah. What about things like crowns and veneers? How does that impact
those are the world of restorative dentistry, and that was my world for most of the early years of my practice. I love doing crowns. I love doing veneers. I love changing the way people look with veneers. And especially having been a dental technician, I love the aspects of what makes a crown really good. But that's really, it's a different world than what we're doing with the treatments in orthodontics, orthopedics, orthotropics, airway growth, orthognathic surgery. If those kinds of restorations for teeth are necessary from a functional standpoint, it's better to do those after you're done moving teeth around.
Gotcha.
If they're necessary for front teeth from an aesthetic standpoint, it's better to do it after you've dealt with the airway. I had a case, his name was Jim, where we did porcelain veneers for all his upper front teeth. It looked beautiful. Within the next few years, he must have broken every single one of them, just kind of ground them off, either made them pop off or more likely just chipped the corners of them. And I redid a few of them, but at the time I didn't know what was going on. I know now for sure he had sleep apnea. There were other signs that were there.
Yeah.
And I know that it was my failure to recognize an underlying airway, occlusion, and functional problem.
Yeah.
So veneers are great, but don't build them on teeth that are in the wrong place. Don't build them on occlusions that aren't functioning in the right way, or there's going to be a lot of trouble later on.
Well, I think they're actually, like with, because you mentioned like clenching and grinding, that's considered with some of the research I've looked at as a sleep disorder. And it's probably, I'm assuming it's a symptom of something like sleep apnea or UARS.
It's not 100%, but I feel like it's guilty until proven innocent. When somebody is coming in and they're grinding their teeth and they have a scalloped tongue, which means indents on the side of the tongue, meaning the tongue is a 6-foot tiger in a 3-foot cage, trying to push out and get more room. And let's say they told me they snore at nighttime. Now I could get rich. If I could just bet the clenching and grinding, the scalloped tongue, and the snoring, I'm sure they've got sleep apnea. It's just a question of how severe. But you get the people who don't snore at all. And there's a woman on my practice, her name's Corey, and she's got a lot of wear on her teeth, tons of wear, but she doesn't snore. And for the life of me, I can't get her to get a sleep study because she doesn't think that there's a problem with the airway. But like I said, probably guilty until proven innocent. Most of the time that reaction of clenching and grinding the teeth is from the sympathetic reaction to the airway starting to close off a little bit. Upper airway resistance, or closing off all the way because of the an apnea.
Yeah.
But yeah, one of the things we can notice, scalloped tongue, a lot of wear on the teeth, recession, broken teeth, clenching, grinding. Those are things that any dentist or dental hygienist can look for and see them as red flags. And then ask the question, do you get to sleep well? Do you stay asleep well? Do you wake up feeling rested? If it's a no to any of those, dig deeper and find out. And the second question is, do you snore? Has anybody told you that you snore? And if the answer is yes to those two, and you're seeing those other structural clinical signs, the odds are it's going to be worth doing a sleep study to find out what's really going on.
Dr. Hockel, I've taken up so much of your time. I appreciate having you on this podcast. You've been amazing. This was super informative. I'm going to be taking notes as I go through editing this. But where can people find out more about you?
About me, our website is lifedentalortho.com. lifedentalortho.com.
Awesome. And you're located in
Walnut Creek, California. It's east of San Francisco, about 30 miles.
Yep. Quick flight from Vegas, so that's why I come to see you. Well, thank you again for your time.
Thanks, Zach.
I would love to have you again at some point. You know, maybe next time you fly down to come.
Hey, you never know.
You never know.
Let's look at doing it again.
All right.
Thank you again.
Yep. Thank you. Take care.
Hello.
That's how it's done.
Keep it.